Good afternoon and welcome to Young ESPGHAN Webinar Series. This is our September and we'll be discussing endoscopy. Together with me, I'm lucky to have Professor Jorge Amil as our main speaker today. We'll start by a few introductory slides about Young ESPGHAN, and we'll give a few more minutes to our audience to all be here for Prof. Amil. Our Young ESPGHAN committee mission, we are here to promote high-quality research and training to our Young ESPGHAN members, and we love organizing activities for us, for our young people. We represent the interests of Young ESPGHAN members within the council and society. At the moment, we have quite a few ongoing educational events. The topic of the month was a project that we started in 2024, whereby using our social media, we present an interesting case in week 1 related to the topic of that month. And then we have our webinar and a paper of interest following in week 3 with a poll at the end of the month. Our Young ESPGHAN Webinar Series, I'm lucky to say that we've had quite a good audience this year, and we hope to continue preparing more webinars in future months. And the mentorship program is now in the 3rd year of hybrid program. So we have an online event as well as face-to-face meetings between our ESPGHAN trainee members and their mentors. The online workshop happened in April, and then there was a face-to-face meeting in ESPGHAN Congress in Milan, and these are followed up by Young ESPGHAN, with virtual follow-up meetings. Young ESPGHAN Day in Milan was quite successful as well. We had a full day on how to showcase our work, how to develop skills and building our careers. And we ended the day with an art and chocolate session, which was quite well attended. This is our group, the group that has finished their mandate and the new people. And if you're not a member yet, please do join us. There are quite a lot of benefits to becoming a trainee member, including a subscription to JPGN Online and the newsletter, reduced registration fees to the annual meeting, and access to ESPGHAN research grants, as well as what you can see on the slide. If you are not a member yet, you can apply by visiting our website and sending us a CV and a letter of support from a full member not serving in the council. Just a few things of events that are happening. There's a masterclass on transition from pediatric to adult healthcare in patients with GI or liver disease. This is only one of the many masterclasses and courses that are happening through ESPGHAN. If you haven't yet downloaded the ESPGHAN app, I think you should. Well, probably you have if you've applied for this webinar, but it's a very useful app to have for our events, podcasts, and guidelines. And the toolbox is very particularly useful. Some guidelines for today's webinar: please mute your microphones. You will be directed to unmute at the end of the presentation by Professor Amil. The chat box is used for submission of questions, and we also have a Q&A possibility for you. If you have problems with audio or connection, switch off your video. And please be aware that this session is recorded for dissemination of scientific purposes. So now I would love to introduce Professor Amil, who has joined us today. Professor Amil has been a very active ESPGHAN member and mentor to a lot of us. He's a pediatric gastroenterologist working in Porto, and has served in the council as a secretary, treasurer, and general secretary. He's a member of the EGID endoscopy and IBD group and was a co-founder of the Porto group. He's a co-author in several guidelines, position papers, and research papers, and is currently serving as the chair of the Public Affairs Committee of ESPGHAN. Thank you, Professor, for being with us today. I'd like to now offer you to share your screen.
Thank you. Good afternoon to all of you. Thank you for the kind introduction and congratulations for the activities of the Young ESPGHAN committee. I've been lucky to have been involved in some of the activities like the mentorship program, and I must say it has been a fantastic experience. I would now then switch to my presentation. I hope you can see this, the screen. Well, this will be a bird's eye view about setting up an endoscopic unit. I mean, although I will be addressing various procedures, for the sake of time, I will not have time to go in detail into each of the procedures. I just thought I could give you an outlook of the equipment and some rules to run a proper endoscopic unit, pediatric endoscopic unit, of course. Well, I have no conflicts of interest to declare related to this talk. Well, I would like to start with a Portuguese proverb. And well, for those of you who are not familiar with Latin or with Portuguese, what says here is that if you are going sailing, you should prepare yourself while in land. Well, this applies very much to endoscopy because we should define the program and make sure that we have the right equipment, the skills to address the problem that we are managing in a certain patient. So always make sure that you have all you need before you start the procedure, because halfway through, then you may get into trouble without being useful to your patients. So this is the translation. And here you see some images of a typical pediatric endoscopy unit. You have an admission room and where the patients then return to after the procedure for recovery of the deep sedation. We have the equipment, and we should always have two monitors available. One is here, the other one can be seen up there, and you can see it here, so that if one monitor fails and we have the endoscope in a delicate position, we are always in control of what's happening. So we have all the equipment. Nowadays, many units use CO2 insufflation, which is preferable to air insufflation, especially for colonoscopy, because it is very diffusible and causes much less distress to the patient. We should have a tray to put in the accessories that we may need to use. This is anesthesiology equipment. There should be a room for washing and disinfecting and storing the equipment. And these are all, well, with this layout or a similar one, the components that should be part of an endoscopy unit. Then we need to use devices. I mean, the endoscope itself is fantastic to look around, to see the lesions, the mucosa, and various dimensions of the examination. But quite often, we need either to take biopsies or take foreign bodies or polyps or control bleeding. So we may need to have very specialized accessories. And there is a very, very wide range. And if you see the catalog of one of the companies, you can see there are hundreds of different devices. So we don't need to have all of them, but we must have a good diversity to cover most of our needs. While foreign body forceps quite often have this rat tooth curvature that helps to have a firm grip on a foreign body to remove. There are various sizes and types of these forceps. Sometimes we have these basket type devices to grab a round object to take out. We have snares. We have tripods. I must say that personally, I have not used a tripod for quite a while because they can be useful, but having these rod net baskets makes life so much easier that it's far preferable to using tripods where sometimes the objects slip away in between these three pieces. And then there are various devices that can be used. I must say, as already you understood, that I am a big fan of these baskets, and we can use them for foreign bodies in various situations. I remember many years ago, I might take almost an hour to grab a coin using a forceps like this, because sometimes the coin would be lying down and then we would not have the right angle. And nowadays, with these baskets, it is so much easier to grab them. So I think this is really a must that you should have in every unit if you deal with patients having foreign bodies. You can see the use of one of these baskets. This is the spring of a device to hold the clothing while drying. And we apply the basket, and I will stop here for, oops, I'd like to stop here for a moment. One thing that is very important when you use some devices like this basket is that when you tell your assistant to close, it is that far end that comes back. So when you use one of these devices, you must be sure that the base of the device is applied firmly against the mucosa, so that when it closes, it does not merely retract around the foreign body. Look, I push down and then close and then grab it properly. And it makes it very easy to grab a foreign body. Well, sometimes we have food impaction, and food impaction sometimes can be mild, and we can gently push it with the tip of the endoscope into the stomach, because the esophagus is the most frequent location. You may try to pass one of these baskets around the food bolus and then try to grab it out. But currently there is a new device from a company that has this clever trick. I mean, you see these two jaws, and this is manipulated and commanded by this thin tube, which is attached outside the endoscope, so that the channel, the operating channel, is still free, and you can put in a forceps. You can grab the food, pull it into this jaw, and then close the jaw and take big chunks of the food at each time you need to do it. So this is also a clever device that, if possible, should be available in case you deal with cases of food impaction. Another situation which is quite frequent in pediatric endoscopy is to manage esophageal stenosis. Well, patients may have stenosis after caustic ingestion, after a battery ingestion, after a surgery that addresses esophagus, for example, in esophageal atresia. And quite often there is a stenosis. Eosinophilic esophagitis is also, though rare in pediatrics, but that may be the case. So sometimes we need to dilate the lumen of the esophagus. There are basically two types of devices. There are these devices which have a fixed diameter. These are called Savary dilators. Usually we pass a guide wire through the channel of the scope. Then we take the scope out while leaving the guide wire in position, and then slide the dilator down the guide wire. And we do this with the first diameter, then we can do with the second diameter. There is a rule of not going more than 3 sizes beyond the initial diameter of the esophagus. Because if you are too ambitious and try to go from this to there, then there is a high probability that you will cause a perforation. Another way of dilating the esophagus is using these balloons. These balloons are also very clever tricks, because we pass the balloons through the channel of the scope, so they are deflated when they get there. Then we inflate up to a certain pressure, and this creates a diameter which is predefined. as you can see here, if currently these balloons have variable distension diameter. So if you use this one, if you use 3 atmospheres, then you'll have 10 millimeters diameter. If you blow up to 5, and we use these devices to blow up the balloon with this manometer to control the pressure, if you go up to 5, you'll get 11 millimeters. If you go up to 8, you'll have 12 millimeters diameter. However, to use these balloons, these are very convenient because you can see what's happening and you still keep the scope inside the esophagus, so you control the dilation. However, you have to be sure that the length of the balloon, which is represented here, is enough to accommodate the whole stenosis that you need to address. You have to make sure that you see this little part, which usually has a different color, can be purple or black or whatever. You must see it clearly outside the scope. Otherwise, you'll be inflating the balloon inside the scope, which is not very good news for your administrator and for your equipment. So you have to put the balloon completely outside the scope before you start dilating. And this table, which is in the package of each of these balloons, they tell you which is the diameter that you can achieve, how long it is, and the pressure that you need to use. Do not go beyond this pressure, because if you do, you'll just burst the balloon. And these balloons are inflated with water. So we fill in the syringe with water, and then we create a strong pressure in the esophagus beyond the point of the endoscope. Another clever trick recently comes from a company that does these dilators, which act very much like the Savary ones, but you still keep the dilation point under view. So you can pass a guide wire, make sure that the guide wire goes through the lumen of the esophagus, and you advance gently the scope, and you create a dilation. There are various diameters of these devices, so you can change from one to the other. And usually be careful, do not push the endoscope beyond the stricture, because if you are too enthusiastic and push the endoscope all the way down into the stomach, when you try to pull back, you may be stuck and the device may detach. Usually we put some tape here to just for good measure, but anyway, there is a risk of creating a problem if it does not come out. So advance into the stenosis, advance into the stenosis, but not beyond the stenosis. Okay, so sometimes we need to control bleeding, and this device is quite important. This is the electrosurgery device. It generates electric current, which is important to coagulate, and it is very useful to manage either bleeding or to manage polyps in patients. So you must have this device. Usually the most modern ones have predefined programs, so you do not have to worry each time about the current that you are setting. You just select the type of procedure that you need to do, and it will automatically adjust. Some of these devices have various modules, and these are built in a way that they can pile up other modules, and they can have also argon plasma, which allows to coagulate lesions in contact with the mucosa. Well, one of the situations that we often have to manage in pediatric endoscopy is polyps, especially colonic polyps. Usually we use a snare. These snares can have various sizes and formats. Quite a few of them are rotatable, so you can tell your assistant to rotate in order to adjust to the best angle to grab the polyp, and then you apply the electric current, and the polyp is cut and can be retrieved. Currently, for small polyps, it is recommended to use cold snares. I mean, without current, because if you use current to take out a polyp, you must be cautious not to use it too close to the mucosa, because it may cause a perforation. Therefore, the procedure itself may include injecting a bit of saline with adrenaline and methylene blue in order to raise the mucosa, and you can see it clearly, and then you can look for a polyp without touching the rest of the colonic mucosa. But for small lesions, using a cold snare and just cutting it's not a regular foreign body snare, it's a snare that actually cuts, and that is quite safe and has been used quite often and has been shown to be safe for small lesions, and the risk of perforation or causing deep burns into the mucosa are not existing because we're not using current. In some cases, if you have a polyp with a large stalk and you are afraid that when you remove it, it may bleed, you may apply these endoloops. So this is also a snare that you pull it to get tight to the lesion, to the stalk of the polyp, for example, and then continuing pulling, it detaches from the device and it is left in place. So you can, so to say, neck the base of the polyp and then take out the rest of the polyp and leave this endoloop in place and reduce the risk of bleeding. Well, for bleeding lesions, we can use different approaches. Well, the oldest one was to inject a product that causes local coagulation. Many years ago, we used adrenaline. Nowadays, it is not recommended to use just adrenaline into a bleeding lesion because you will control the bleeding for a few minutes. You take out your scope, you go out for coffee, and the patient may be bleeding again. So adrenaline may be useful to control the major bleeding and clear the fluid and the field, so to use other technique, but not as a single way of addressing a bleeding lesion. Quite often we use clips. These clips can be opened. Some of them can be rotated and can be opened, closed, and reopened again. It depends on the brand and the type. There are very clever clips currently, but then you tell your assistant to close the clip. You look for the bleeding lesion, you close the clip, and then by pressing further, the clip detaches from the device and stays in the mucosa, and it will drop off a few days later. As I mentioned, sometimes you can apply electric current. You apply this forceps, and with a bit of electric current, you can coagulate the lesion locally, or you can use this gold probe, which allows in contact. You need a special source, of course. You're in contact with the mucosa, it causes very fast coagulation. Another recent advance is argon plasma. Argon plasma is deployed through a catheter without actually touching the mucosa, and this electric current and the gas will coagulate the mucosa. And depending on the definition of the current, you define how deep you want to address the coagulation. There is also an auxiliary device which uses this trick applied to the tip of the endoscope, and this is the cannula for the argon plasma. And by using this, you can have a good view and apply it at 90 degrees onto the mucosa without obscuring your view. So it is an advance to this one, but the principle is the same. Well, sometimes we have bleeding in the stomach without having a single vessel or a single ulcer, and the mucosa is just covered with blood with erosive gastritis. And currently we have, well, this is one of the brands. There are other products, but the clever thing about this particular product and similar ones is that they are deployed through a catheter outside of the scope, and they are deployed near the mucosa, and this is a powder with coagulating properties. So it is like a fire extinguisher. You apply it onto the mucosa, and the bleeding stops almost immediately. Well, the negative part of this particular product, apparently not so much with more recent brands, but with this particular one, is that once you apply it, it looks like a hazy day inside the stomach because it becomes very cloudy and you will not be able to see anything else. Everything will be whitish. All the mucosa will be covered by this powder that becomes very sticky onto the mucosa. So you have to see and do whatever you have to do before addressing the bleeding, because once you use this, there is nothing more to do. There are some specific notes about using this particular hemospray, is that any drop of water inside the tubing will coagulate the product, and this tube will be to waste. Therefore, this is applied inside the scope without connecting to this device. Then a few syringes of air are pushed down the tube in order to remove any remaining drop of water that may have been collected while traveling inside the channel of the scope. And only after that, you apply it here, you open the valve, you open there a canister, there's a small metal canister with a pressure gas in here that is opened by twisting this, and then pressing this button deploys the powder onto the mucosa. It is really very effective, although in severe bleeding, there must be a reviewing of the bleeding next day or in 2 days, because there is a small risk that bleeding may restart again. There are some publications about using this device even in esophageal varices, in bleeding esophageal varices, not as a final treatment, but you may use that as a temporary measure to control acute bleeding and then make plans for the subsequent treatment in the patient. Well, if you have esophageal varices, you can inject them with a sclerosing agent, but in small children, that is still the best option. But if the patient size is big enough, then you can apply these ligators. These are elastic bands. So we apply the scope against the varix. We apply suctions, very strong suctions, so the varix comes into this cup, and then by pulling the wire, this elastic band is deployed around the varix and ligates the varix. And we can use a good number of them. When you see the different color, it means that you only have one more to deploy, so that you can control how many you are using and how many are still left to use. In older patients, bigger patients, there are this over-the-scope clamp, which is also a clever trick. It is a bit frightening. It looks like a bear trap, which is applied outside the scope. You can have a forceps pulling the lesion inside the scope, and then you deploy this big clamp. And it can be removed later after some days of controlling the situation. One frequent situation we have in pediatric endoscopy is to manage foreign bodies, and some of them are sharp. Therefore, the risk of pulling out the scope with the foreign body and causing further lesion is real. Therefore, we have to use some tricks to protect the mucosa, and this is one of them. There is this bell-shaped hood in rubber. We put it at the tip of the scope, fold it back, and then we push in the scope into the stomach, and we grab the foreign body with the forceps and then pull it back near the scope. And once we pull the scope through the cardia, this hood will unfold and will create this bell-shaped rubber device, and the foreign body will be inside of it, therefore protecting the mucosa. So this is quite cheap, and it's useful to have a few of these available if you need to take out a foreign body like a pin or whatever foreign body, a blade or whatever that may be dangerous for the mucosa, you can use this device. Another trick for small foreign bodies is to use the cap of the band ligators. You grab the foreign body, if it is a small one, like a small pin or something, you grab it inside this cap and then take everything out. Sometimes we have devices like this, and this might injure the mucosa while pulling it back. Therefore, protecting the mucosa with this hood can be quite useful. So I told you that you can keep and disinfect and sterilize the band ligators cap and use them for some foreign bodies. Well, beyond using the endoscope, always make sure that you have some additional tools, because sometimes we grab the foreign body and we're happily pulling it back, and once we get to the pharynx, it drops out. So it's useful to have laryngoscope and a Magil, apologies, and a Magil tweezer in order to grab it from the mouth or pharynx. Always make sure that this is available to be used if needed. So it's fantastic to do endoscopy and procedures, but there is a lot more than that in endoscopy. And we must have pre-procedure items like inform and obtain signed consent from parents and the patient if appropriate, inform and be reassured about following the fasting time to make a safe endoscopy. The only exception to this is the ingestion of button batteries, where sometimes we have to do it with much less than that, because the risk of very deep perforation of the stomach is very high. Give good instructions for bowel preparation when appropriate for colonoscopy. There are various protocols. I'm not advocating any of them, but some protocols with smaller volume, like picosulfate, can be better accepted by children, because some of the protocols with polyethylene glycol may have a large volume and they start vomiting and not taking it all, and it is very embarrassing to go through all the pains of the procedure, of the preparation, and then having a colon filled with stools. So perhaps options with smaller volume may be quite interesting and palatable to young patients. Also, it is useful to assess and record the bowel preparation. There are various scales, and you see this is one of the scales that can be used between excellent and inadequate preparation, and this can be done in general, or you can see another score is the Boston preparation scale. But this one you use by segments, left colon, transverse, and right colon. So it is quite similar to the previous one, but by each segment. So you can choose whatever you find more convenient for your own practice. Well, as you certainly know, there are guidelines about indications and how to perform some endoscopic procedures in children, and this is certainly very important. But there is more than that. I mean, having quality in endoscopy is not only about choosing the ideal moment or the ideal technique for a given patient, and also making sure that the whole procedure is performed with quality is quite important. Therefore, a group of authors from Europe and North America worked together reviewing the literature, and we called it the Penguin papers, and these were published jointly. There are 3 papers published in a supplement of JPGN, and I encourage you to go and read them because it's quite important. And I'll just go through them very briefly. There are various domains addressed in these papers. One is the broad area of pediatric endoscopic care, about the process, the performance, outcome, and the quality improvement, and measuring the performance, the quality, and the clinical quality. You may consider the quality of clinical operation, which addresses the time frame as specified in specific guidelines, whether the guidelines for sedation are actually being followed, the rate of errors that we perform, like mishandling or mislabeling or misprocessing tissue specimens, and the rate of adverse events, and participating in a quality assurance program. Well, we are always very sad and sorry and try to not talk about our own mistakes, but it is appropriate that we keep a good record of what went right, but also what went wrong in order to improve for the future. Well, we should listen to our patients and caregivers. So we must see whether they received and understood clearly the instructions, the bowel preparation, the discharge criteria, ask them how they feel about the service they received, and make sure that this is formally obtained. I stress the importance of informed consent. In Portugal, whenever there is some litigation about medical malpractice, if there is no clear documentation of a signed consent form, then the physician is immediately found guilty. Therefore, always inform your patients and make sure that everything is properly documented. Well, documenting the indication for the procedure, it is in accordance with existing guidelines, consent was obtained, all the relevant information, clinical information was taken from history and physical examination of patient, the documentation of the sedation used, if there was prophylactic antibiotic treatment, and there are some situations where we recommend that. For example, when a gastrostomy is done, usually there is prophylactic antibiotics given, and there are some situations where the risk of infection is higher, and therefore this indication is even stronger. During the procedure, make sure that before you start, everyone is fully aware of what the plan is for the procedure. Everyone is informed about the condition of the patient, what you plan to do. Of course, we may adjust depending on the evolution of the endoscopy, but we should have a clear plan before starting. Monitoring of the patient should be done always by someone who is not the operator of the endoscopy. Make sure that all medications used are documented, the comfort of the patient, have available reversal agents, and if used, document that. If a procedure needs to be terminated prematurely, that should also be registered. Qualify the bowel preparation and the quality of this preparation, inspection of all relevant areas for the procedure that was planned, and which interventions have been performed. After performing the procedure, instructions of what the patient should be doing, what care should be taken, make sure that pathology reports are properly communicated, adverse events, late adverse events, and make sure that the findings from pathology are properly reviewed with the patient and the caregiver. Training of endoscopists is quite important, and there should always be someone who's been fully trained and credentialized for the procedures. The pediatric endoscopists' practice and competence should be assessed. The number of procedures that are usually performed each year, how often cecal intubation is achieved, ileal intubation, where and when each of the operators has achieved competence, and if there is a regular program of reassessing and making sure that competence is maintained. So all these items that I mentioned are quite important, not to punish anyone, but to be used as a cycle to plan, do, study, and act in order to improve what was not perfect at the first time, and therefore to improve the quality of each one of the operators, but also the overall quality of the unit. So coming to conclusion, please, if you are going to do endoscopy, assess the problem and the likely cause, select and prepare the tools that you may need for the procedure. Always consider a plan B if something goes wrong. Sometimes a device falls onto the floor or breaks or whatever. So there are emergencies where we must have a plan B available. Have someone who knows how to assist you during the procedure, and engage into a quality of practice program in order to make sure that your unit and your service are always on the improvement care curve. So thank you so much. Well, Anne-Marie already mentioned to you this masterclass on transition. Well, pediatricians in general are very motivated to hand over patients to the adults. However, our adult colleagues not always are so motivated. There are some skills that pediatricians should learn, because transition is not a single moment, it's a process that must start well ahead of the final moment. Therefore, as pediatricians, we must know these tricks, but our adult colleagues also must know how to hand over the young rebel adult, and how to manage the missing appointment. I mean, all sorts of difficulties that happen, how to manage the family. Therefore, we hope to meet in November, mid-November. Registration is €100 and covers accommodation in Porto. It will be dark and raining, but I promise you a very warm welcome and a very good time, also listening to some of our patients and parents. So thank you so much for attending this webinar. I'll be more than happy to try and address any questions. Thank you.
Thank you, Professor, for this wonderful talk. I think it ticked all the boxes when we asked you to go through how to set up a pediatric endoscopy service. We'll open the chat box and the Q&A. We already have a question from Pinar. I'd like to thank Pinar. So thank you so much for this very informative and helpful presentation. What would be the best treatment option for a 1-month-old with a delphi lesion, which is bleeding extremely, in case we do not have any neonatal clips?
Well, for a 1-month-old baby, probably the best option immediately would be to inject. I would inject with diluted adrenaline and control it at the moment, and then try to have clips. Well, a 1-month-old baby, you need to use a neonatal scope. Therefore, you cannot put clips because they won't go through the channel. So the best option would be immediately to inject the lesion. But then you have to go back and make sure that the bleeding has been controlled. Neonates usually have a low blood pressure, so the risk of major rebleeding is not very high. But a neonatal scope has a very thin channel. Therefore, you have to manage any action within that very small channel. So I think if I was faced with that case, I would try to use a neonatal scope, an injector, and then control the bleeding after having done the first endoscopy.
I hope that has answered Pinar's question. While we wait for more, we do have more questions. So, no, that's fine. So while we wait for more attendees to ask questions, I'd like to ask Professor. I'm not sure in terms of our audience what type of training they have and what experience they have through endoscopy. One of the things I face on a daily basis is challenging the admin people when I tell them about new equipment. And obviously, because our numbers are so much smaller than adults, it is always challenging. Have you ever, how do you go about this, like cost analysis and how to make use of the resources you have and choose the best equipment with what money the admin team can provide you?
Well, the first informal rule, I often say that it is worse to bear with me than to please me. Therefore, we really have to be persuasive. If you work in a pediatric hospital, then everything is thought about children, and therefore this discussion is not so difficult. When we work in a general hospital, as I did for many years, then it becomes really very difficult. We have to make a case for our patients and explain that children need proper care. They are not just small adults, so it's not useful to go to rush with our patients to the adult endoscopy because they have big scopes, they have big devices which may not be appropriate and don't even have the experience. And some situations are a bit different in pediatrics than they are in the adult world. Therefore, going to the administration, to the clinical director, and explain to them that our patients need also the best care. And we must make a list of the equipment that is usually required, some more often, some not so often, and then provide regular reports on what we've been doing. Because if we do not tell them how much and how hard we are working, well, we are just a small voice. We are just as important as ENT surgery or ophthalmology or anything. I mean, they regard us as just a specialty, which is completely inappropriate because we manage all sorts of diseases in an age group, and therefore we need to provide them the best care. So it's a lot about persuasion and making a sensible list of the devices you may need. Some devices can be shared with the adults. I mean, if you need to do a polypectomy, I mean, you may share the equipment with the adults, with the adult gastroenterology. We don't need to have everything in duplicate, but we must have the devices appropriate for the type of patients that we manage. Yeah.
And I believe even the channel, because obviously the pediatric scopes, when you're using therapeutics, you have to be careful that the channel is smaller, so not all of the equipment is available. We have a few more questions.
Just let me tell you that when Hemospray came out, and I wrote a letter to the administrator, I was allowed to buy 4 kits of Hemospray, and sometimes the adults would borrow one from us when they needed it because they still did not have access to it. So sometimes if you are persuasive enough, it may work the opposite way, yes.
So a few questions. So one of the questions was in terms of anesthesia. Is it mandatory to do general anesthesia for all patients, I'm assuming, or sedation is okay? And from which age would you use an adult scope?
Well, it depends. The type of sedation depends on the procedure you are doing. Well, for colonoscopy, I really think that having anesthesia, or I mean, deep anesthesia, deep IV anesthesia, is far more comfortable for our patients because it can be quite uncomfortable, and we don't need, well, today medicine is so advanced that there is no room for having someone uncomfortable. So we can make good comfort to patients. I must say that, well, for several years, in the middle of the night, I used IV midazolam to sedate the patient for an emergency endoscopy, to take out a foreign body or a food infection. But as much as possible, I think that having an anesthesiologist sedating the patient is far more comfortable. So that should be the regular rule, with a few exceptions in some cases.
And
the question is about
what age?
Integrating pancreas. Sorry.
So
for age for adult scopes. Well, I must say that from 10 kilograms onwards, we can use scopes about 8.5 or 9 millimeters with minimal resistance. So probably above 10 kilograms, we can use a bit larger scopes. I mean, well, if you consider therapeutic scopes with 2 channels, that you need patients that are much bigger than that. But for patients 2, 3 years of age, I think we can usually use scopes around 9 millimeters or 8.5. Yeah.
Now, another quite interesting question is about the penguin guidelines. What is your opinion, and would you suggest integrating them into the daily endoscopy practice?
Well, my suggestion is that a group working in a given unit looks at all those various standards. It's a huge list of standards and topics, and you start with one of them. I mean, you may start with indications for procedures, and you concentrate and you practice on that. And then later you move on to the next level. I mean, you don't have to do everything at the same time at once. You select the ones, and there are some, well, the paper, if you read the papers, there are some basic standards that should be implemented everywhere, and those are easy to implement. I mean, they do not require very specialized equipment or devices. So you can start with the basic ones, and once you feel comfortable and you feel that that is helping to improve the quality, then you can move on to the next steps. So it's not a one moment procedure, and you can gently join and persuade the National Society so that everyone is implementing the same type of evaluation, so that everyone is getting better.
Thank you for your answer. I think from what we're saying is that most often what we need is a lot of persuasion to try to get everyone on board. We have Monica, who also asked us a question. Should we consider pneumatic dilation in children with achalasia or POEM surgery? Or POEM surgery should be the first choice in that case? And from what age or weight can we use a 30 millimeter pneumatic balloon dedicated for achalasia? What is the difference between an achalasia balloon and a standard one?
Well, achalasia can be managed in different ways with different results. Currently, the implementation of either the Heller procedure through laparoscopy or the endoscopic, the POEM, the endoscopic technique, have shown excellent results. Therefore, I would recommend, if a patient has diagnosed achalasia, I would recommend to use either Heller's or POEM, depending on the experience of the surgical team doing it. I mean, it's, well, doing POEM, if you have ever seen a video of the POEM process, I mean, you almost feel your heart stopping, because you can see the pericardium and the heart beating just outside the thin membrane, and yet they feel very comfortable going down and coagulating and cutting and all that. So in experienced hands, it's a fantastic procedure, but that requires experience. If not so much, then Heller's, the surgical approach, is quite effective, again, depending on the experience of the surgeon. Other alternatives, like pneumatic balloon dilation. The balloons, starting with the type of balloon, the balloons for achalasia are different from the regular dilation balloons. They have a much larger diameter, as you said, around 30 millimeters, so 3 centimeters balloon, which is quite a large one, and the pressure created is much higher. Therefore, for an adolescent, you can use this type of balloon, but I would only consider balloon dilation if a patient is not able to eat anything and needs immediate relief, and then I can do a dilation, 1 or 2 dilations, while the surgeons organize whatever they need to do to operate on the patient, because usually the dilation gives a temporary relief. So it can improve the quality of life of the patient for a few weeks, but it will not be a definite final treatment. Another alternative is to inject Botox. That's results are also temporary, usually three to 4 months, and then you would need to do it again. That could be done in a patient who is very severely malnourished because cannot eat anything. So the surgical risk is a bit high. Therefore, you may try to gain some time by doing dilation and injecting Botox. The patient will start to eat, and then once the nutritional condition has improved, then you could organize with the surgeons. So the first option would be for surgery. Second option, or either Hellers or POEMs. Second option, dilation with a temporary relief. Third option, dilation plus Botox.
Thank you. Another question from Dr. Hind. I do colonoscopy on my patients, but I always find difficulty in doing retroflexion. Any advice?
Well, patience. I mean, it depends on the size, or on the age and the size of the patient. You have to push in the scope a little bit and try to find room in order to do a proper flexion, complete flexion of the tip of the scope. I mean, it requires I do not have any special trick. You just, it's a bit like in the stomach when you had to see the fundus. You have to look for the best position where there is some room for the tip of the scope to move about and flex. And well, just don't be too aggressive. Try to push in a little bit and go on rotating the scope while trying to flex and find the best position in order to achieve a complete retroflexion.
I think that was the last of our questions. Don't know if you have any final tips or advice that you'd like our audience to hear?
Well, I suggest that those of you who are serious about doing endoscopy, you may join one of the various initiatives for training. There are hands-on courses. ESPGHAN this year had, as usually we have during the annual Congress, you just have a brief touch, I mean, a brief contact during that ELZ area in the Congress, but we had a fantastic course in Athens only a few months ago. There was also a course last week here in Porto, in Portugal, in Braga, near Porto. There will be a hands-on course, at least we hope we can do it, a hands-on course during the World Congress in December in Buenos Aires. So there are always various options. Try to go to one of them because not every country can provide all the resources and experience, but these hands-on courses, they unite the best experience across Europe. And the course in Athens was just fantastic lectures and demonstrations. And those of you who were there will probably agree with me.
I do agree. I heard quite good feedback about the course in Athens. Before we finish off, there are just two comments, if I may. So Monica has asked if fluoroscopy is necessary for esophageal dilation procedure.
Well, if you use a Savary dilator, that can be useful if you have the resources again. If you have the X-ray equipment inside the room, you may use it. As a general rule, I do not use it, but in some cases when I think that could be a difficult case or a very thin, very strong stenosis, I might prefer to use it. And you can control the progression of the dilation. There is a particular situation where the Rome group does a very interesting procedure, especially in cases where passing the scope causes trauma, like in epidermolysis bullosa. These patients sometimes have esophageal stenosis, but they bleed so easily by the touch of the endoscope that it is possible to pass a very thin scope and pass a guide wire, then take out the scope and under X-ray control with fluoroscopy, you slide a balloon down the guide wire and you start inflating gently the balloon below the level of the stenosis with a radio-opaque contrast. And then you pull back very gently the balloon until you see a sort of an hourglass effect at the level of the stenosis. And once the balloon is in that position as controlled by fluoroscopy, then you can blow up the balloon and create, the stenosis. You can see the release of the stenosis with the balloon, then deflate and take it out. So you can do a forceful dilation using fluoroscopy rather than creating additional trauma with the endoscope inside the esophagus. In other situations, like putting in a dynamic stent for some recurrent esophageal stenosis, we really need to have X-ray control to make sure that the stent is located exactly at the level of the stenosis. So there are some situations where we must really have that. In other cases, it's convenient, especially in dilations, it's convenient to put in a bit of contrast after the dilation to make sure that there was no perforation. Well, not all of these cases will need fluoroscopy, and that means exposure to X-rays, which is of some concern, but some procedures actually need to have fluoroscopic control.
And Andrea has commented on achalasia. So her comment is that for achalasia, esophageal manometry may help differentiate between the types, as it is shown that there is a different efficacy of POEM versus HALER according to the type of achalasia. And surgeons might not like the idea of a dilation prior to the surgery, as it leads to fibrosis and impacts their outcome of surgery.
Well, I completely agree. I mean, if you work with surgeons, you know how difficult it is to manage some of their habits and beliefs. So having joint plans for patients makes complete sense. And there may be a point in this objection about creating some fibrosis. And if the result is bad, you will be the guilty one, of course, because you were messing around with the stenosis before they actually did their magic. So it depends. And if you work closely with a surgeon and you can make a plan for quick surgical treatment, there's no need in creating additional inflammation in the location. But if you cannot get in touch with the surgeon, or the patient cannot be operated so soon, you cannot just stop the patient. You have to make some provisional treatment. So in general, I agree with Andrea, but we have to adjust to the local setting and the local resources to make a plan for the patient. And working together with the surgeons is quite important.
Thank you for your last comment. I think we have now neared the end of our webinar. We're exactly on time, 18:02. So I'd like to thank everyone for joining us today. We've had quite a good audience, 50 participants. We're quite pleased. And we'd like to tell our audience, please join us for the next webinar in October. More information will be on the ESPGHAN website quite soon. Good evening, and thank you all for joining us this evening.
Thank you very much for the invitation. Bye-bye.